have to do you have to like admit the participants in or do
Yeah,
they admit?
I do have to admit them in, but okay,
Mm,
so far now no one's coming in, D.
all
So
right.
yeah. Oh, just as I said, someone came in. All right. So welcome everyone. I am Dr. Jaren here today, representing GDPA, and welcome to our Buka Mulut episode 3. So who are we? We are GDPA. We are General Dental Practitioner Association. Basically, we would like to represent all general dental practitioners in Malaysia. I mean, it doesn't that even if you are not like a, I mean, even if you are like a specialist or anything, you are still counted as a dentist in Malaysia. As long as you're a dentist in Malaysia, welcome to join us. And we just want to maybe make a shift or make a change in our dental industry. I know it's been very stressful for so many people. So one of the reasons why we have our Buka Mulut is we love to talk so much. Uh, so this is one of the reasons that we can talk more. And hopefully, because this Buka Mulut session is more of a casual session, we don't want to make it into a lecture or or webinar or anything like that, because everyone is very stressful already. So everyone finished work now, we're here. Let us relax. And today's topic, we will be talking about reality of smile design. And with our Dr. Ian Foo from Penang.
Hello.
So welcome, Ian, today. Thank you for joining us today. Ian is a very good friend of ours, and he's my junior from Masa as well. We've known each other for a very long time. Feels like we were childhood friends. Yeah. And Ian is now in Penang practicing with Smile Bay, and I will let him introduce himself a little bit later on. And he has also started teaching as well. Even conducted a course with MetaDen last year, and
Mm.
now he's here to speak with us tonight. So I think we have quite a lot of things that we can, talk about today. So without further ado, Dr. Ian, would you like to introduce yourself?
Yeah, sure. So first of all, thank you very much for the introduction, and thanks to GDPA for inviting me over to talk on this Buka Mulut session. And like Jaren said, I was told that this is going to be a very sort of like a casual, discussion and my sharing of my experiences. Not so much of a very clinical lecture. All right. So, and I hope that this is will be an interactive session as well. So feel free to use the chat section, and maybe we can have a Q&A after everything. Or if you have any questions, I think you can just go ahead and type at any point of time lah. Okay. So maybe let's just test the chat section. All right. So if you can hear me, please type one. Type one so that I know that you can hear me loud and clear. Can we see some? Yep. Yep. So everyone can hear me, right? All right. Awesome. Thanks so much. Okay, so just a very quick introduction. I'm Ian Foo. I'm born in Penang and I studied in Masa University. So like Jaren said, Jaren is my senior, very, very close with him. I remember when I just joined in, first year, Jaren and the gang, their year, they were like the ones how to say, doing the ice breaking and taking care of us. And until now, after so many years after we graduate, they are still taking care of me.
Consulting from you, maybe.
Yeah. And currently I'm back in Penang practicing with Smile-based signature. Okay. And well, I'm doing general dentistry, but with a focus on using digital tools to help my practice. So I do a lot of guided implants and also smile design, which we are going to talk about today. All right. So Jaren, how are we going to chat about it? Do we want to open the slides or do you want to talk about?
Sorry. Yeah, you can. Yeah. So I thought you wanted to show the slides of your uh,
Oh, okay.
introduction, if you like
Sure,
to.
sure, sure. I can.
Yeah.
So maybe I'll just share my screen. A share. Hold on, yeah. So I'm just going to share my screen.
Yeah, Ian works in a very chunky place right now, and I think it's very beautiful place that he's working right now in Penang heritage area.
Yeah.
Superpower, man. Superpower.
I mean, if you guys are in Penang, give me contact me, drop by for a visit. So I prepared a very, very short presentation, just a few slides, not more than 10 probably. But yeah. Anyway, just a little bit more info of me, where I crossed paths with digital dentistry. So during Masa University, I think I was very fortunate to be with a batch of colleagues that all of them were very enthusiastic about digital dentistry. So we started with buying secondhand DSLRs, buying things online from Shopee, those retractors for mirrors. Right, so we were really playing with digital photography. And then during the gap year, I actually somehow managed to work with Vartech Malaysia, which is a digital X-ray company. And there I was first exposed myself to digital X-rays, which are what you know as OPGs, and also CBCTs today. All right, so CBCTs, I mean, it's a very good tool. And if you have a CBCT in your practice, you really need to sort of like get used to familiarize yourself with how to actually manipulate the software to make the most out of it. All right, so in government, of course, not so much of digital technology, but I did take a course on implantology and learn about guided surgery. And right now I'm in Smile Bay, where I really got my hands dirty. And as you can see, the logos below are some of the technologies that I work with. All right, so I rely on tree shape a lot. Serec as well for my same visit crowns. We also have the Medit scanner, Vartech GreenX. We also have an in-house lab that is equipped with the Konzan system, the CAD-CAM system. We have frozen and anycubic printers. Our in-house lab also has a Sprintway. And in the clinical side of things, we have the Zeiss microscope, and maybe not so much digital, but it's a microscope that helps in endo, and also the water lace to do laser dentistry. And this is a pretty cool drone shot that I took one day when I didn't have so many patients. So I hope you can see this video though. So this is where
Yep, it's running. It's good.
Yeah.
We can see you.
Yeah, you can
And you.
see trying not to crash the drone. All right. So yeah, and this is how our waiting area looks like. It's a pretty nice place. So if you're in Penang, hit me up. Maybe you can drop by for a visit. And this is the clinical area with 5 on the first floor. I mean, on the ground floor, we have 5 chairs. And this is the central sterilization unit. All right. And this is the bigger room lah. Okay, so this is the surgical unit that has a little bit extra space just to keep all the surgical instruments, implant models and stuff. What I like about our practice is that we have these really huge TVs in front. And actually, can you see my pointer, Jaren?
Yes, we can see your
Yeah,
pointer.
okay.
Yeah.
And this Antos chair can actually sit upright, like 90 degrees. So it's really nice to put patients up to actually consult right in front of them, show them their x-rays. And yeah, so today we'll be talking about digital smile design. So maybe we won't continue with the slides right now, right, Jaren?
Yep.
Yeah, we will just go back out and we'll just have a talk, some sharing.
Yeah, so like I think digital dentistry is not, I mean, it's very common into everyone. I think everyone's very familiar with it and all this kind of thing. But how did you actually begin your journey into like specifically into like, digital smile design? Like what got you into it?
Yeah. So actually, I mean, like you said, most of us are quite involved with digital dentistry in some way or another. And I would say digital dentistry is a spectrum, right? You can have just one tool and make the most out of it, or you can have everything, and have a fully digital practice. But I mean, as long as you have one or two tools, as long as you can maximize it, try to learn how to fully utilize it. So I would say that when I really got into digital dentistry is when I got the chance to play with the 3Shape intraoral scanner. So in Smile Bay, we acquired the Tree-shaped Trios. That was our first scanner. And back at that time, intraoral scanners were marketed in a way as, a way to how to say, just in a way to replace impression material.
Impression materials, yeah.
And they were talking about how fast they can go, speed and whatnot. But nowadays, these intraoral scanners, it's taken for granted that they are really good. There's no question about doing impressions or intraoral scanners anymore. So now they are marketing more tools other than just taking scans. They are equipped with softwares to do DSD. They're equipped with softwares to do surgical guides, equipped with softwares to do checks on their occlusion and whatnot, right? So the intraoral scanner would be, if I were to pick one instrument that made me learn a lot, would be the intraoral scanner. So
yeah, I agree also. Definitely the intraoral scanner. I think as a new user, the intraoral scanner also, I think it has made my life way, way, way easier. Less messy also. Because at one point that I had to make a decision whether I want to upgrade a CBCT or a scanner. What will you choose?
You already have a CBCT, right?
No, I don't have a CBCT.
Oh, okay.
Before I had a CBCT and a scanner, I was choosing between which one to pick first.
Okay.
So if you have the decision, I mean, like which one would be more important, or which one will make a bigger impact in practicing in your practice?
Okay. So that's a very good question. But I would say that depends on what type of dentistry are you practicing, because these two tools are very important. I use them almost every day, both CBCT and the intraoral scanner. But I would say that if you're going into implants, going to surgeries, then definitely you might want to look into prioritizing the CBCT.
Yep.
Right? Because the CBCT is the only tool that can show you a cross-section of the bone, of the mandible or the maxilla, the thickness of the bone. Is the only way you can tell the thickness. I mean, other than opening up a flap and looking at it directly, right? So if you're planning for implants, going into all surgeries and all this, then definitely you have to prioritize CBCT. Whereas on the other hand, if you are doing more towards ortho, doing general dentistry, you're doing a lot of crown and bridges. I mean, even if you do dentures, intraoral scanner.
But in terms of like you doing smile design, like doing.
So if you're going to focus on only smile design, then definitely the intraoral scanner. Yeah.
Yeah, definitely. And then just going back to something that you mentioned with the CBCT when you were talking about it, like how does CBCT like affect, I mean, make a difference in terms of smile designing?
In terms of smile designing,
Yeah.
so I would say that the term smile designing, all right, when we think about it, it is mostly talking about doing veneers or sometimes crowns, right, in the anterior region. So I would say that CBCT doesn't really play a role unless you are planning for a smile design that involves, let's say, implants or maybe all on fours, something like that. Or of course, it comes in handy to take a CBCT when you're doing this type of rehab cases, just to make sure that what you're veneering on or putting a crown on is not a periapical lesion tooth, right? But in the sense of the DSD process, CBCT might not be really very relevant.
Okay. Yeah. I guess so too. Yeah. I think the scanner will make a bigger impact when it comes to yeah. So how would, I mean, since you are fairly experienced already in smile designing, what would you say the learning curve is like for people who like wants to get into it? Because we're talking about the reality of small design, right? Everything looks very nice. All the before after pictures look, wow, so good. But actually there's a lot of work that is put into it. So like if anyone wants to get started with smile designing, I think what's the first step that we should be taking?
Okay, good. It's a very good question. So I think before I answer that question, I just want to know a little bit more of our participants in terms of their experience with smile design. So for the audience here, all right, can I just ask a question? If you have done anterior crowns or like something like a smile makeover, let's say 4 or 6 units of the anterior region, regardless it's a veneer or crown. If you have done it with DSD or any form of planning, please type 1. I just want to understand like how our participants are like. Have you, I mean, everyone listening here, have you tried any form of DSD? Please type 1. And if you have done anterior crowns, anterior veneers without planning, that means just LA prep and then send to the lab, without any planning, without any DSD, please type 2.
Can I do 1 and 2 at the same time? Maybe
And
way long back, maybe it will be a 2, but now it's definitely a 1, I suppose.
okay, maybe the third category would be if you have never done any anterior crowns or smile makeovers, please press 3. Right. So I mean, I just want to understand the audience so that I can curate my answer in a more relevant manner.
So far, we have more 1s.
Okay, so
Like
far.
more 2s, actually.
Oh, okay. Okay, cool. All right, so it's a mix lah. All right. So I would say that definitely, if you do a lot of anterior crowns, yeah, I would consider as long as you do more than 2 units and involving the anterior region, you should consider going into DSD. And I would just like to share my experience in going into DSD. At first, it was very intimidating, definitely, because when you talk about DSD, at first I thought it was like a tool, a single tool that I can buy, or is it like an app that I should purchase and subscribe, something like that. Then
Yeah, that's
as
what
long
I
as I
thought at
just pay
first
a lot of
too.
money and just get it, then I'll be able to do all these things, right?
That's what I thought too.
Yeah. So, but I mean, if you look into the whole process and understand, I took some time to actually understand and go and research. I realized that DSD is actually just a process. Okay, a very good comparison or analogy would be like guided surgery. Everyone knows the surgical guide, right? But if you talk about guided surgery, it's really a process, or it's really a spectrum. You can have like a Essex retainer, right, and put a hole, and you can call it a surgical guide, but it's fully analog, right? Or you can have a full, 3D printed guide, stackable guide or whatnot, and it's also considered surgical guide. So DSD is something similar. You can mix and match with a bit of analog, a bit of digital, whatever you have on your hands, as long as you have some way to plan it, then it is a form of DSD, and you should do it if you're doing anterior crowns and whatnot. Okay, so my journey was started, like I said, with the Tree Shape. And the Tree Shape has a very good app on DSD. It is a smile simulator where all you have to do is just put in the patient's photo into the software. So Tree Shape either comes with a cart or the trolley thing, which has a built-in screen, or you can have a laptop. So what I do is usually I will just put in a photo, sit next to the patient, and it's sort of like a wizard where you just click next, you just choose the teeth, how many teeth, what type of templates you like, right? And then of course you can do some fine tuning, and it will ultimately, the last step would show a visual simulation of what you have designed to the patient, and you have a very nifty feature where you can click and just slide back and forth to show the patient. Right, so that is sort of like the most basic DSD you can do with intraoral scanner. Of course, there's a bit more to it, and I'll talk about it in a while in terms
Do you
of
have a case that you can show that it was with the DSD thingy?
Yeah, definitely. I'll go into the details about that.
Maybe you can have a look at it, or
Yeah. Okay. So maybe.
Yeah. So now we check out a case where how the process is done. I think that would be great.
Okay, sure. So since we are talking about the process, okay, I will split it into 3 visits. Okay, 3 main points, or in my case, 3 visits. So the first visit, what I do is I sit the patient down, I take photos of him, and then in front of the DSD software, in my case, the Tree Shape, we will do a very quick DSD simulation. Okay.
Are you sharing your slides?
Can you see? Sorry.
No,
Oh,
you're not shared yet.
hold on. Hang in there. Let me share my screen. Okay, so just a very
Yeah.
quick overview of my process. Okay, I split it into 3 different parts. Okay, so the first part, I do all of this in the first visit where I take photos of the patient and then I sit him down in front of the tree shape software. And this is how it looks like. Okay, if you see this part, the lower left side, you can actually choose different libraries. You can see oval, triangular, and whatnot. Okay,
It's
and of
all
course,
preset already, lah.
it's all preset. And then, of course, you can toggle the width, the height, right, the smile curve, and whatnot. And then what you can do is you can further fine-tune certain areas. As you can see, when you put your mouse here, it actually has a crosshair for you to fine-tune all of those. And then once you click to the last slide, it would be something like this, where it will actually overlay a texture over the frame that you have designed. Okay, and go back and forth. So this is where a lot of discussion, a lot of communication with the patient is done.
Do you do this live? Like when patient is here, they
Yes,
take
yes,
picture
yes.
a day and then like right there and
Right.
then, right?
Yeah, I do this live. So because it's live, patients are free to actually comment on it, you know.
Yep.
We'll have a lot of back and forth with the patient. Right? And then after this is all done, dismiss the patient, verify that he likes this, dismiss him. And then what I'll do behind the scenes is that I'll transfer this 2D design into a 3D software. Okay, so this is the behind the scenes part. So on the right side, this is the tree shape studio, if I'm not mistaken. It's called the design studio, sorry. So design studio is doesn't come with your intraoral scanner. It's a lab site software. You have to pay or subscribe to use it.
Okay.
But because we have an in-house lab, so we have this software. But mostly this part would be done by the technician. But it's good to know what's going on behind the scenes, right? So in my case, I do it myself. I will overlay the whatever I've designed in 2D. You can see the one behind. Ignore these 3D crowns or veneers here first, but you can see the frame behind. This is imported into the 3D software. And with similar points on the scan, that means I import my 3D scan as well. Similar points on the scan and the photo, we'll align that, and then you can then do the designing. So when I'm done with the 3D design, I open up the 2D overlay and to see whether I'm following whatever I've designed with the patient, right?
Yeah.
So whatever I'm designing 3D is in fact what I have discussed with the patient. So once that is done, I'll print this out in a model. Okay, and then I will do a party index.
Okay, right.
So the next visit would be the actual day of the prep. So we have the party index done already. And of course, with this party index, there's a lot of things you can do with it. First of all is that before you prep, if you press it into the patient's mouth, you can actually have a pre-prep mock-up, sort of like just to convince the patient further. If you have a very nervous patient or patient that has a lot of questions and want to see before you prep, you can actually do a pre-prep mock-up, press it in. And then, of course, once you press it in, you can use it as a reduction index, or you can prep through the mockup. Okay. And of course, the party itself, you can cut it up to turn it into reduction indexes, right? And with the party and the reduction index, you can prep according to the plan. And the whole point of doing the party is to temporize with the plan design. And it is, for me, it's very important because imagine a patient coming in with because he's not very satisfied with his teeth, right? That's why he wants to do a DSD. And imagine if you don't plan all of this, you're going to just take a party of his original teeth, right? So that means the patient come in and leave your place with the same appearance, or not maybe
no
worse, because you are doing
Yeah.
chairside, things get messy, right? So if you do all this beforehand, right, your temps will look good. Not only they look better, but they are what you have already discussed with the patient since you've done all the transfer from the 2D to the 3D, right? And the beauty of having it in real life is the patient can look at mirror. And also if he still wants to further customize it, for example, if he feels like, oh, this angle is too sharp, canine is too sharp, you want to round it off, you just use a disc to do the changes. You can add on composite or whatnot. And take a scan of those changes and send it to the lab. Right? And then lastly, the third visit would be the issue without any issues, hopefully. So because you have done everything beforehand, you have planned everything. So basically it wouldn't be too much of a surprise already.
Yeah. Yeah.
Because patients have mocked up everything, and when you send the scans to the lab to ask them to replicate it. So whatever you have in permanence is what is already been discussed before, right?
Mm.
Yeah. So
Yeah.
this is the whole workflow for DSD.
Would you say, like, I think from the whole process, I think would you say like the mock-ups are one of the things that really make the biggest difference?
It does.
And
It does.
like, things that you can that we can expect, or
Definitely.
in smile designing. I think that's like one of the biggest key thing that
It is.
will help with your workflow and all.
Well,
Yeah.
definitely the mock-up is very important. Actually, Jaron, what time do we end our session? 9 o'clock, is it?
Yeah.
Yeah, okay. So I mean we have a bit of time. Let me just do a real life an analogy, a very good analogy of DSD. All right.
Okay. Yeah.
Using a real life example. So let's do a role play, Jaron.
Okay.
Imagine that you are going to buy a car
Mm-hmm.
and I'm the car salesman. All right. And to
Okay.
have this context is that you are a layman in terms of cars, right? All you know
I
is
I am a
English.
layman in terms of cars.
Yeah, me too. All right. So just imagine that all you know is that you want to get a new shiny, maybe a white car, something like that, right?
Mm-hmm. Okay.
Do this role play. Okay. So yeah. Hi. How may I help you today?
I'm looking for a car.
You're looking for a car.
Yeah.
What color?
Preferably white.
Preferably white. And any idea like what type of car? I remember you're a layman, so you only know like some like maybe is it a family car or something like that. Yeah.
Yeah, well, can seat maybe 5 people
Sit five
comfortably.
people.
Yeah.
Okay,
Yeah.
so you want a new car that's white color, can sit 5 people. Okay, yeah, understood already. You can make the payment and come in next week. I'll have the car ready for you.
Oh, what car is it?
Yeah, you'll see next week.
Oh, like that.
Yeah, just make the payment and I'll see you next week. All right. Okay, bye.
Okay. Oh, okay.
So,
Bye. Bye.
do you have a lot of questions there?
Yeah, of course. Yes.
So that is how I feel an anterior smile makeover feels like without DSD.
Hmm.
Right? Because let's
Yeah.
say if you're doing a DSD and the patient comes in and he wants to prep, then of course, the patient is also a layman.
Yeah.
Say that, okay, I want nice whites and straight teeth. And your white and his white you have different definitions.
Yeah.
And what you're going to do is just going to LA everything. You're going to take a party, you're going to prep and give him back his original, give him back mock-ups that are in his shape of his original teeth. Right? And
Yeah.
then he comes in next week. So, like, there's so many chances of surprises, unpleasant
Yeah.
surprises,
Exactly. Yeah.
errors, right?
That's right.
So I mean, nowadays, if you go and buy a car, the car salesman is going to show you an iPad. Even if you don't know heck about cars, right? He's going to show you all the different libraries. Or you have this type car, SUV or whatever, right? And then you
Yeah.
have mock-ups as well, where you can choose the color, change the different sport rims or whatnot. Again.
Mm-hmm. Mm-hmm.
Yeah. So
Yeah.
and then maybe when you order in the car, then or maybe you can go for a test drive first, right? So basically doing a DSD is something like that, where you sit down with the patient, you have an iPad or a screen to have all these libraries where you can visualize the patient or himself inside,
Yep.
have a proper discussion, and then plan everything. So when the patients come in for the prep, you already have a very good visualization for the patient. And on top of that, it is customizable. You can further
Yeah.
fine-tune it. All right. And then the cherry on top is that you can scan it and send to the lab.
Mm.
So it's a whole process where it streamlines everything. You have a good communication with your patient and your lab.
Yep.
At the end of the day, it's a win-win situation for everyone.
Yeah, definitely. Definitely. But okay, so we are talking about what we saw just now was like you were using the tree shape software.
Yeah.
So what about those who do not have the tree shape software? Like
Okay.
any recommendation that you would advise?
So okay. Basically nowadays, if I'm not mistaken, most or all intraoral scanners will have their own DSD software. Okay, but if you don't have an intraoral scanner, what I used to do was I downloaded Medit Link. So Medit is also another brand of intraoral scanners, but they're very kind enough to provide a free software. So basically, you can just go
That's
ahead to
awesome.
Medit, create an account and just download for free and use the software for free. You
What's
don't need to
the
link it. It's called Medit Link. So you don't have to link it to an intraoral scanner or anything. You can
okay.
download on desktop and play with the tools. So with Medit Link, there is also a free DSD software that you can play around with.
Oh,
Yeah.
okay, okay. Yep, yep.
Okay. So
Is
of
it?
course, because it's
Yep,
free,
yep.
so it might not be as streamlined. You might need to play around, do
Yep.
a bit of research, and they also have a YouTube channel where they teach you a bit of how to use their software.
Mm-hmm.
But it's a very good tool because you can in fact use it for your patients. You can upload it. Maybe you can't do it live in front of the patient, but you
Yep.
can at home upload the patient's photo, do a planning,
Yep.
and you will get what I had with the tree shape, which is a 2D with the smile frame. You can then use it to show your patients, and you can also send it to the lab where the lab can transfer that to their 3D design. Okay, so that is one thing to look into.
Okay, I didn't know about this Medit thingy.
Yeah,
MEDIT and then LINK, is it?
correct. So Medit is another intraoral scanner brand, but they have this software for free. And other
Yep.
than DSD, there are some other useful softwares that I use.
Yep.
The model builder, where you can build your models from your intraoral scans, and then you can export it into your 3D printer to print. So it's quite useful. Yeah.
Okay, okay. So I will get someone to share the link inside here to share with everyone the Medit web page. Yeah, Shana has shared
Yeah,
it. Thank you
Shana
very
has
much.
shared it. Thanks, Shana.
Nice. Yeah. So with this, I think I guess we can play around and all. This is exactly the same by the Medit scanner. It's not exactly the same lah, but it's similar lah, right? But at least it's a good start that you can do. You can use it for maybe not live with the patient. Maybe you can take the pictures first, and the patient, then you book another appointment for the consultation with the patient the
Yeah,
next day
yeah,
while you're ready to show it to
definitely. That's
them
definitely
already.
doable. Yeah.
Yeah, yeah.
Because I
That's good.
remember, I mean, maybe when we were students, we went to these conferences and there were already talks about DSD. And at that time, DSD was using, can be done with just PowerPoints or
Yeah.
presentations,
PowerPoint or Keynote.
or Keynote, yeah, where you have
Yeah.
these templates and you just put in the patient's photo, which is exactly the same. It's just now it's all
Now it's all just
defined.
clicking and selecting.
Yeah,
Back
and then
then
you
it's
have
so hard. You have to like 1 2 1 2 and all. Cause I mean I actually went for a course with that, and then like I was using a Windows, but everyone is using a Mac. So obviously using a Mac and the keynote is like way easier. And then like the kesian the speaker that she has to teach, like teach me window fella. Okay, you need to use PowerPoint and do this, but then keynote is so easier, so much easier to do that.
yeah,
But now with the software and all, I think this makes such a big difference. It's so easy
exactly.
right now.
Exactly. And
Yeah.
you have immediate, visualizations where they overlay the different textures.
Yeah. Yeah.
Of course, you can toggle the color as well. That's very important because the
Using
color
color
is
makes
something that
it's a good
is
feature.
very subjective. When your patients say they want white, but then when you show them like, oh, white, then you show them BL range, like BL3, BL4, then they say, oh, too white, you know?
Do you have like patients who want like super white? I mean, you always
Yes.
call like toilet white, but then do you have patients that like sometimes like okay, let's say if you don't like the white, right? And
Uh-huh.
then patient also die doesn't want a white. Would how I mean you do you just go with it, or like it's not gonna look as good already if
Yeah.
it's like that white. Like
Yeah.
how do you speak to the patient about it? Or you just go
Okay.
with it?
I guess also this also depends on how familiar you are with that, right? So I'm very lucky to have an in-house lab where I can discuss with my lab technician, and I already know what is their work like, right? So knowing all this, I would say that my limit would be BL4, which is whiter than A1. You have the bleach range, and the whitest is BL1, next BL2, BL3, BL4. So I'll go the whitest will be BL4. All right, because anything whiter than that is really too white and too opaque. Okay, but I've done maybe a few cases, two cases with BL4.
Oh. Okay.
And they all turned out quite well. I mean, it's what the patients want. And with the right texture and the right staining, they can look quite good. But my personal preference would be within A1 or A2.
Do you still think that it's still too white with the BL4?
Personally, I would think it's a bit white. It's a bit white, okay? But I mean, duty is in the eye of the beholder. So different
Yeah,
people really
yeah,
have different preferences. And you're
that's
working
right.
with different type of patients as well. So for example,
Yeah,
I had this expat, very nice guy, and he requested very white to match
yeah.
his hair,
To match
right?
his hair.
Yeah, because he has this very beautiful white hair, combed down,
Nice.
very nice white hair, right? And he said he wanted white teeth to match his white hair. And when we simulated everything, and it turned out really well. Yeah.
I assume so.
Okay. So
Yeah,
maybe I can
yeah.
show you a case of the BL4.
Oh yeah, that'd be great. Yeah.
Yeah. So again,
Do
share
you
my.
have do you have anyone who comes to with a blonde girl or a blonde guy coming in? I want yellow teeth to match my hair.
No, never, not yet.
Yeah. Okay.
Okay, can you see my screen? Yeah. Okay, so
Yes,
this
we
this
can
was
see
the
it now.
case just now. I think this is just A1, I think, or
A1.
A2, I don't remember.
Okay.
Okay. Yeah, this patient, what he requested for was really, he said white, so I showed him A1, and he said that, you know what, because I'm already doing everything, right? Might as well make it like really, really white. So we simulated it in the
Yep.
software. He was quite comfortable with the wider range. So this is actually BL4.
Ooh.
But it could be a BL3 also. I don't remember already. But as you can see, I mean, of course, different people will have different preferences. Ask me personally, I feel it's slightly towards the wider side of things. But
Yeah.
I mean, it still turned out quite nice. With some texture, with some staining, it still looks somehow natural, especially in real life. It looks quite natural, and the patient is very happy about it. I mean, no point if you don't like, as a clinician, you don't like a very white color, right? And then you force the patients into something that you feel is natural, but the patients end up don't liking it, right?
Yeah, that's
No
right.
point to
That's
that.
right. I think
So,
he's investing in the future because he knows his hair is starting to turn white already. So it's gonna match in maybe 5 years time.
this is a different patient, but yeah, possibly. Yeah. So, and to stress my point again, when you're talking about colors, it is so subjective. I mean, I can't imagine without a software or without photos, right? When your patient he wants white, not too white, then how are you going to define what type of
What is white
whiteness,
and what is not
right?
white? Yeah, that's right.
Yeah, so with a software, you can just bring up the brightness of the colors, or you can change the warmth of the teeth, right? Of course, it's still not, you still don't have like settings to put it to A1 and A2, right? Software up to that level, but I can bring up the brightness and bring up the warmth.
Right.
And then from there, you can actually gauge what your patients like.
Mm.
Because you'll be surprised when you do DSD, right? Patients say, "Oh, I want very white." You say, "Sure, you want very white." Then you put white, then say, "Oh, maybe too white."
Yeah.
Yeah.
I think
So
the tool really makes such a good like definitive answer that patient can like the choice for patient to pick from.
yes, and it
Yeah.
can be the other way around. So some patients they come in, they say, "I want natural, I don't want white, I want a bit yellow." Then when you put yellow, patients say, "Oh, let's spend so
Yellow.
much. Maybe I want whiter." So it's so many surprises.
Yeah. I
Yeah.
used to the other way that I used to do last time was just putting composite and then like okay apply one and then okay see the difference, okay you want this white, not white enough, okay change another one, bleach shade composite and then put it there again, then like choose. Yeah, so it's so different now, it's so easy right now actually.
Yeah, that's
Yeah, well, but although of course definitely there's a learning curve to it lah, like
right.
adjusting the warm and the the brightness of the tooth is also another thing that you need to learn also, right?
Yeah, but I mean it's pretty easy as long as you know how to use a computer. I mean, these are all click, and they are designed to be easy to use, very streamlined. Yeah. So, but of course, like I said, the Medit, it takes a little bit of time to get used to because it's free. But nonetheless, it's still quite easy.
Okay, what are we looking at?
Yeah, so just this another case of quite a recent case that I've done. So also a veneer case. For this patient, okay, case selection as well lah. I would say that if patients have teeth that has obvious issues, usually they are slightly easier to do, right? As compared to like someone who already has very perfect teeth and they still want it better, then that is a little bit challenging.
Yeah,
So for
that's
those who
right.
are just starting out, I mean, this case is you can see obviously one of the tooth that has something like an abrasion or an abfraction over there, right?
Yep.
You have crack lines, you have wear and tear. Of course, the shapes are all slightly different. Okay. So these type of cases, and of course, the patient is a very nice patient as well. So it's quite a straightforward case. So with the planning, okay, we can do something according to her liking. So this is the molar to molar veneers.
Oh, wow.
Yeah, molar to molar veneers. And very interesting thing that I realized after doing DSD, okay, you see how she smiles before?
Yeah.
She accommodates to the teeth, you see? See how her smile is a bit more narrow. And if you in pre-op photos, I always realize I tell the patients to smile wider, but they still
Yeah.
can't smile very wide, right?
Yep.
But
Yep.
when you issue the veneers, you can see how patients it changes their confidence, I would say. Changes the
Yeah. 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 Definitely.
yeah, she always wanted a wider smile, and now with veneers, we are able to plan according to her preference, and now she smiles so naturally, so happily. She even shows the lower teeth. So,
Yeah.
and okay, yeah, okay. This is just a compilation. So on the top left is the pre-op. This is the 3D planning. If you see
Okay.
closely behind the 3D teeth, you can see the template there, and the 2D template.
Yeah.
This
Yeah.
2D template with the frame is all done with the 2D chairside software, or you can do it in the Medit link. You
Yep.
then send it to the lab, and the lab will overlay this 2D photo to the scan, and then they'll design accordingly. All right, so I've designed according to the patient's preference, and then transfer it into the patient's mouth. So after the prep, this is the mock-up. Okay, and then this is the issue.
Yep.
Right? Yeah. So very good tool again. After you do the mock-up, it's just a good touch to just scan again and send it to the lab so they can transfer this new design if you have done any modifications to the yeah.
I think your mock-up is so similar to the final result, actually.
Yeah, I mean that is intentionally done, all right? Because I mean it's no point if you design it in 2D and you promise the patient what she wants and whatnot, but if you don't transfer it to a 3D, then it will have a negative effect.
Yeah, for
Because you
sure.
over-promise and you under-deliver. So I mean these are all tools. You have to learn how to use it. So even for the 2D DSD, I actually learned it sort of like the hard way. Because in 2D, you can actually design, the perfect smile. You can close all the gaps and whatnot. But in real life, some teeth might be, procline or retrocline or whatnot. So you also need to be careful. You need to practice beforehand to roughly know what is possible, what is not possible. Okay, so yeah. And generally, we are able to copy the shape, maybe just some minor adjustments, like for example, patient prefers like a more angled edge. So we just you can add on composite here, or you can trim or whatnot, scan.
Yep.
Yeah, you can see how the mockup and the finals are quite similar.
Yeah.
Mm.
What about like for less lucky people like me who don't have a lab and then cannot transfer the straight to a 3D, right? Like
Yeah.
from the mock-up, then what do we have to do?
Okay.
Like in order to communicate with the lab, like, okay, this is what I want. This is like okay already.
Good question. So, like I said, smart design can be a spectrum, right? So at least now you know that you can do the frame with Medic. Okay, so the minimum is you just need a camera and you need a computer, and then you have this smile frame already, right?
Okay.
So you can send that smile frame to the lab, ask them to prepare a 3D model, then they'll send it to you, and you do the putty, and then you can still do all the same steps where you press the putty in. Okay. And also you can, in the mouth, adjust some more if the patients need any adjustments. And then what you can do, to answer your question, is to take an impression. Take an impression of your mockups, point into the model, send back to the lab. And the lab can always digitize it by scanning. And so basically you can still achieve the same results.
Yep.
Yeah.
I get questions like, oh, if you take an impression of the mockup, right, will it fall off when you take out the impression? So far, I think it's not happened to me, but I don't know whether it's happened to you or not.
Okay, so well, I've never taken impressions for mockups because I do a scan. I'm very lucky. Okay, but I can imagine,
Yeah,
of
lucky
course.
you.
Yeah, so I can imagine. Definitely, it depends on your prep as well, lah. If it's just the very minimal or even no prep, definitely it's gonna drop out. Okay, so what I suggest is what I can think of is, you press it in, all right.
Yep.
And then before you take it out to re-cement it or what, you straight away take an impression. Okay, so if it comes out, then you're going to cement it back with a temporary cement anyway. Okay,
Yes,
in
that's good.
some cases, very minimal preps or let me think. For example, in some wrap around preps as well.
Okay.
Where when you press it in, okay, you can just leave it in there and polish it in the mouth, and then it will be sort of like locked in already. Okay, so I don't take it out again to re-cement because I feel that once you take it out, it's not gonna go. It's either not going to go back in, or you're gonna trim away all the undercuts, and when you put it in, it's going to
maybe loosen
sit
on
well.
later on.
Yeah. So but you can only do that if you have a very good mock-up beforehand, and also very good mock-up and also a very good putty. That's very important. Okay, because otherwise, if you just simply do it, when you press it in, you're gonna have all these flashes everywhere. It's gonna be very hard to trim. You will defeat the purpose of actually doing all the visualization because it's gonna be very messy. And then of course, obviously, it'll cause gum inflammation. So during an issue, there's gonna be a lot of bleeding and whatnot.
Yeah, that's right. So how do you so I think just thinking about one of the stuff like when we start off doing all this more of like small design thingy with the temps, since we're talking about the mockups and all.
Yeah.
So one of the I think common questions people ask is like after the mockup, if you take out a mockup, how do you like, clean your mockup well so that just emitting someone so that you maintain your perio side nicely. Sometimes when you take out the temps, then the gums start bleeding and all this kind of thing. How do you manage this?
Yeah, so that's why a very good mock-up is very important. And it starts off with, a very good temporary is very important. And it starts off with a good mock-up. Okay. Reason why is that imagine if you don't do a mock-up, you're going to take the impression of the patient's original tooth, right? The original tooth might not be in the correct position. So you're going to cause a lot of flashes of the temporary material. So mock-up, number one, very important. Two, your putty is also very important, actually, because if you just press down the putty, you'll notice that when you take it out, if you look closely at the putty, maybe I can go back to my putty photo. Yeah. You can see how the interdental areas, they're very not defined. It's supposed to be very sharp, right? But you see this is wide. Because in fact, the putty is just too viscous. It's not flowy enough to go into those interdental spaces. So when you do that, your mock-up will not turn out very nice. So what I do nowadays, if I have time, I will do a putty wash. That means after the putty, I will press a light body or
in.
press it down. Then you have very nice fine edges. And when you do that, you will have a very nice mock-up. Okay, where these are more defined. And of course, it won't be perfect. You can use a needle finishing burr to actually round things off and polish it very nicely. So actually, once you do this, and of course, given that patients are OH is good. When the patient come back, they don't bleed. They only bleed that if the mock-up is really, too many overhangs. In fact,
overhangs and all.
I have learned it the hard way because once my mock-up actually extended a little bit too much. And when the patient came back, there was a bit of gum recession. So that's going to be a problem. So mock-ups are very important.
Yep.
Treat them as like a main step in your procedure, because I think some mistakes are that you think mock-up is just a temporary, just like a placeholder so that the patient can go back or so that they don't feel sensitive. Not really. I think you have to think of it as actual prosthesis.
Yeah,
It's
yeah,
temporary,
that's
but you
right.
need to treat it properly. You need to design it properly. You need to execute it well. Not only for the aesthetics, but for the gum health as well. Yeah. Okay, so yeah, I do polish my temps, polish to a high shine. You can either polish to a high shine or do a rough finishing and use a glaze material. So, for example, there is you guys heard of Luxatemp?
Yep, yep.
Luxatemp also have a Luxatemp glaze,
Mm-hmm.
where it's basically just a clear resin that is light cured. Right, so you do a rough
Ah,
finishing and you just apply this glaze light cure and it'll be nice and shiny already.
nice.
Yeah,
Easy.
yeah.
Okay, yeah.
Yeah.
Speaking about mock-ups, I think I and everything is so perfect in you. Maybe I should share something imperfect and let it come from me. So I got
Sure.
something to share to you.
I stop my share, huh? Okay, yeah.
Yeah, sure. Let me just, I don't have all the pictures with me, but I think I can do this with everyone should be able to see it clear enough.
By the way, is there any questions from the audience? Oh, we have 40 participants though. I thought it was just
Oh,
20.
yeah, we have wow. Okay.
Okay.
Okay. I don't know what you're seeing right now, but can you
I can
see?
see 2 photos.
Yeah. Okay.
Yeah.
So this so this is one of the patients that I did a mock-up and can I zoom in more for everyone to see it? Okay, cool. Can you see the zoom in?
Yes, I can.
Okay. Yeah. So of course everyone see your perfect work already, so everyone might see my crappy work as
No, I
well.
only
So
show the perfect ones, man. Not perfect, I don't show it.
yeah, but just just for discussion's sake, on the left side is the first one. There's it's a bridge here on the 1 to the 2 1. Okay, so I did a mock-up for the patient, and then after that, when we reach the issue stage, this thing happened. So if you can see, the 2 1 is saying it. Does it look say yeah? Saying see the 2 1 is saying it. Yeah. So from here,
Maybe you have to zoom out a bit because when it's you can't really
to appreciate it a little bit more, right? Okay.
Yeah.
I hope everyone can see as well. If you can't see, just let me know in the chat, okay? Yeah, so you can see that 2 1 is saying it right now. And then I decided, okay, I'm not gonna issue this, and then the patient also feel like it's very weird and she didn't really like it. So we send it back to the lab to fix it. And then maybe also my part in the communications where I did not do a scan. I think maybe it will work well if I did a scan on what's going on right now here, and then the lab can actually interpret it even better. So I send it back to the lab and then just send the pictures to the lab and say, okay, this one's saying it here already. So and then the lab said, okay, I'm gonna fix it, and then they done it already. They send it back to me, and then when I issued it, I didn't really cement it down when I put it in, the 2 1 is all right, but ended up the 1 1 becomes saying it.
Okay. Yeah.
Okay,
Yeah.
thing like that can see,
You see
right?
that.
Yeah, now we see that the 1 1 is saying it pula. And it's the same crown. I don't know what happened, same bridge, so I don't know what happened to it. But yeah, so the lab also like, how come like that one? And I'm like, yeah, how come like that one? Like 1 1 was fine. How come now 1 1 become like that already? So so this was one of issue that I faced before doing smile design. And I think anywhere that you can suggest to like improve this kind of thing, I think like communicating with the lab side, I think that would make a difference avoiding this kind of problems.
Yeah. So just to understand the case a bit clearer, you took photos of so for the photo on the left, after you tried it in and you saw that it sang it, you took this photo and you send it to the lab as well, right?
Yeah.
And okay, so in these type of cases, if this were to happen, what I'll do is that definitely I'll take a face photo
Mm-hmm.
and I'll try to take a record of the mouth, be it a scan or like in your
Mm-hmm.
case, you take a model,
Yep.
all right, so that they can actually pour it out and you send these two information to the lab. So again, what they can do is that if you send them a model, they can digitize it by an intraoral scanner.
Yep.
And then they can overlay it, they can overlay the 2D photo
Mm-hmm.
and the 3D scan, and then they can see how much to actually correct. All right, so that is one way.
Okay.
But what I like to do is that, so unfortunately, this is already the zirconia. Is this the
Yeah.
porcelain, right?
Mm.
So what has happened to me before is that after I did the 3D mock-up and whatnot,
Yep.
and prep and transfer into the patient, then I realized, hey, actually maybe the midline is a bit off or there's a capping or whatnot. So
Yep.
because it's still a mock-up, I can actually trim or I can add composites and mark the midline clearer.
Mm-hmm.
And then after I visualize on the patient, I ask the patient to sit up and see properly, let the patient see the mirror, they're happy with it.
Yep.
Then I take a scan, take a photo, send it to the lab. So the lab needs to have the face photo and whatever that's in the mouth in order to correlate and understand whether there's a canting or not.
Okay.
All right, because without it, if you just send a scan, all right, what the lab sees is literally just a scan, and the first thing that any technician or even I will do is I will align the scan
Align
to
it.
the horizontal plane, right? But
Yeah.
who knows, because the patient might have a cant,
Yeah, that's
right?
right.
So you
That's
will
right.
just align it properly, do a very nice straight crowns, but unfortunately in the patient's mouth it's not. Right? So
Yeah.
very
Yeah.
important facial photos, and somehow a record of the mouth via the scan or some impressions.
Yeah. I think photos is good, but I think it's not enough. What I could have done is like take an impression of it, like what you say, and then after that, then they can interpret a little better.
Yeah, that's right.
Yeah, that's
And
right.
in this case, I would say that maybe a little bit of canting of the midline, not so much of like the on the left side. It's not so much the 2-1 is senget. I think the 2-1 is quite okay. It's just that the distal line
Yeah, the distal
slightly
line
flat
is
out.
bit is
So in
in,
fact,
yeah.
if that is what the patient is okay with, and in fact, if the 1-1 also had something symmetrical, it would be quite straight already, actually.
Yeah.
But for the second one, I do see that the midline is slightly canted towards 1-1.
Yeah. Yeah. Yeah.
So I mean,
So
sometimes unfortunately things happen where you already did your part, you already communicated everything, but it could be some sort of error, miscommunication. Maybe you contacted one technician, but the other
another
technician,
one took it up.
yeah.
Yeah.
So sometimes it still happens.
Yeah. Something. No, I mean no game blaming anyone, but yeah, I think it do happens sometimes.
But yeah,
But
I mean, that's the thing. It's not about blaming, but it's just understanding that because it's so many step process, there's
yeah.
bound to be an error along the way.
Yeah.
All right.
Yeah.
So how do we actually minimize it? Which is doing all those
Mm,
records, planning, and whatnot.
yeah. And now with the scanner, I think scanner really makes a big difference, like this
Yes.
in terms of this view that
Mhm.
we're talking about. Yeah. But
Yeah.
okay, at least luckily patient managed to then this case was done, and then was
Yeah.
way better than what it was before.
Yeah,
Yes.
definitely.
Yeah. So I think people were happy, and luckily let me charge me for it. Okay.
Nice. Yeah.
Yeah. We do have one question here,
Mhm.
Ian. Let me just stop sharing. Have I stopped sharing? Okay.
Yep.
Yeah. So we have one question here from GG. Thank you for your question. It says,
Usually.
"Hi, may I know how to bond the temporary on the prep?"
Okay, so very good question, because technically we don't want the temporary to bond onto the teeth, but at the same time we want it to be stuck there somehow. All right. So it depends on your prep really. Of course, if it's crowns, okay, or if there is a combination of crowns and veneers, you're not too worried. Okay, so imagine like, let's say the canines, for whatever reason, the canines are crowns, but the front are all veneers, right? So that's easy because it will rely on the retention from the crown. Okay, so you can just use your normal temporary cement. But if you're talking about all veneers, then again, there's variations. If it's a wrap around veneer, okay, where you prep the interproximals, but you don't prep the palatal, right? Just a wrap around. That is also quite easy. All you have to do is with your proper putty, you press it in, And once you remove the putty, it will be locked in interproximally. Right? So I don't usually take it out. I will just polish it intraorally. I mean, remove all the flash, polish it intraorally, and leave it there. So the next time when the patient comes back I've never had this scenario where the patient actually drops the veneer in that type of scenario where it's a wrap around.
Okay.
In fact, it's quite hard to remove. So you have to be careful. You have to trim through the proximals. Be careful not to touch the prep and then remove it one by one. But if you're talking about really just the labial, those
Surface.
minimal prep, okay, it still depends. If there is some black triangles to lock in, it will still stay. But let's say in a scenario where there's none, okay, what you have to do is you need to rely on bonding. Okay, what I do is on the prep teeth, I blow dry everything nice and clean already. I put a spot bond. So I spot bond right in the middle third of the areas that I want to bond on. Okay, spot bond. And it depends on, it really depends on case. I don't really spot bond all the teeth, but I spot bond strategically, maybe every other teeth. All right, and then again, I press down the temps and let it set there. So it will bond directly to the spot bonded areas. And I always put it on right in the middle third, because if anything, if it's really bonded on, you can just prep away and it doesn't really affect your margins rather than putting it on the incisor or on the margins itself. So I hope that answers your question.
Okay, yeah. And we're past 9. I think we've got more to talk about, but then, yeah. Anyway, I think we can take one more. Or is this a question, Keith? Thank you for a wonderful sharing, Dr. Ian. How did you train your aesthetic sense to be able to cater to the patient's aesthetic requirements right away, live? Or is it with the Trio Smile Simulator, or is it just being very well versed with the library, like seeing? I think experience comes with choosing the templates as well, right? Or do you have a set kind of? All right, I know your facial shape is like this. This template would sort of fit you, and then you play around with that.
Actually, to be honest, maybe it's my library. I mean, the version of the tree shape that I have. Most of the libraries are a little bit out of whack. You know, they are like, some are really very straight, some has worn off edges. I mean, very, very niche, very specific kind of designs. I would say 70% of them are like that. So the 30% are the more natural ones, like they have oval, triangle, square, right? So most of the time I gravitate between just one or two only, which is the oval or triangle or something like that. And then I do fine-tuning from that. Okay, and of course, being well versed with the software is very important. So initially, of course, I don't do it in front of the patient. I do an additional visit.
An additional visit,
additional visit just to make sure everything is okay. You know, so I do it when the patient goes home, try to play around, maybe make one or even two DSDs so that. But after you do it a couple of times, you get really used to it and you can do it immediately. And use a mouse, because mine is a cut, so it's touchscreen. But yeah, without a mouse, it's very difficult. So on the mouse, if you have the laptop version, then it's fine.
I think the mouse with the mouse really makes life a bit easier compared to the touchscreen. Can you share how do you start up for your first few smile design cases?
How do I start? I guess I think the question is that correct me if I'm wrong, are you asking like, how do you build the confidence to actually do a full smile design? Is that what you're asking?
More of like, what was your, you say yes.
So, okay, because I'm a very, I always play safe, okay? So I started quite slowly, I would say. I case select. So in fact, when I just started in private practice, if patients want more than like 2 or 3 crowns, I would just let my senior do it. I would start with single cases, right? And maybe I was lucky because somehow I was quite chronological. I started with single crowns, and then somehow or rather, patient wants to change 2 crowns. And then at one point of time, I had maybe I'll consider my first aesthetic case where I did 4 crowns. And 1 week later, I had a patient that fell down who broke the 5 crowns. So I was quite chronological lah.
Oh my God.
I think you build the confidence first with the clinical skill first.
Skills first,
So
yeah.
prep needs to be fast. Needs to be fast and accurate. Then you need to understand the margins, your clearance and whatnot. And once you got the tough parts away already, that means you're quite well versed with prepping, scanning and whatnot. And then you'll be quite confident in doing all this DSD, because the DSD part is really quite simple once you get used to it. You just need to get used to it. But the tough part is you can't run away from the clinical skills. Prepping, So yeah, if you're starting up, try to case select. Remember, try to choose easy cases first, easy preps, easy patients. All right, if your patient is quite demanding, maybe you want to refer and observe your senior do it. That's where you gain the confidence.
Nice. Okay.
Question.
We have one more question, but we'll answer that and then we'll wrap it up. But before we do that, just a little announcement that Dr. Ian is having a course coming up soon. At end of the year. Yeah, you do, I think. He and Dr. Ho, Ho's the Ian, will be conducting a course in December this year, which will be all about digital, from surgical guides to smile designs, similar to what we had last year, but it's gonna be way better, I'm pretty sure, right?
Yeah.
So just keep in mind. He'll be doing it with MetaDen. So if you're familiar with MetaDen or not familiar with MetaDen, do search it up. It's META Meta DENT then on Instagram. We have a Insta page there for you to know more about the courses that MetaDen is having, which will be in collaboration with GTPA lah. Okay. Yeah, so we move on to this last question and then we'll wrap it up. So this last question from Dr. Hema. Doctor, do you do smile design with composites? And what are your thoughts on it as a definitive treatment?
Okay, so to answer your question, I don't. But you can do smile design with composite. Basically, you can still design everything 2D, 3D, print out a model. And ultimately, you will, instead of doing the normal putty, you will take the clear putty. The clear silicone putty.
You're talking about injection molding, I think.
That's the only way that I think of where you can actually transfer your design into reality with composites. So that is one way. But what are my thoughts on composite as a definitive treatment? I guess I can't really comment on that because I really don't do a lot of composites for definitive like smile makeovers. Of course, restaurant 1 or 2 teeth, yes, but I don't do composite resin veneers. Maybe it's my preference, but I did see a lot of cases where that there needs to be redone or needs to be polished with stain margins and whatnot. So I don't do them lah. That's my personal preference.
Okay. Thanks for the question as well, Hema. I think with the injection molding technique, I think that's great. We think we had a course that we collaborated with Dr. Nazreen as well about injection molding technique. I think that was very good and one of the more accurate ways. I think it's one of the ways that is one of the trends that's picking up right now. I think Dr. Nazreen taught about injection molding was very throughout the course was very good, and actually understanding the technique really makes a difference if you want to go with composite as your treatment material. I think injection molding is something that you should look into it, Hema. So with that, we thank you everyone for being with us, and we thank you, Dr. Ian. Thanks for tonight.
Thanks for
the chit chat.
It's been, thanks everyone for spending your random Thursday night. 2 PM already. I hope all learn at least something. All right.
So that concludes tonight. We will be having few more episodes. So follow us on Instagram, GDPA. You can find us GDPA, General Dental Practitioner Association, for more episodes. If you missed it or you want to share it out, we will be uploading this episode onto YouTube. We have our episode 1 and episode 2 on YouTube as well. We talked about, I think, splints, and one more is photography in orthodontics. So today is with Ian. Now we'll be having our next episode next month. So yeah, keep your notifications on for our group, and we will see you all again. Thank you so
Yeah.
much.
Thank you. Thank you, everyone.
Thank
Thanks
you,
for
everyone. Have a
watching.
good night.
Yeah. Good night.
Bye bye.
Bye.
Let me off the recording and